Good evening, everyone. After a lot of complex cases, I will be presenting a very simpler a variant of a cuff tear. So this is a 51-year-old female, just regular slip and fall, just presented 3 weeks following the injury, and she was inability to lift the right shoulder. So these are her movements. Right side is the affected one. So we can see that active forward flexion was just about 70 to 80, and the active abduction was also restricted. She was not able to do the abduction, and the rotation also, there was no active external rotation, suggesting there is could be an infraspinatus tear, and the internal rotation as well was restricted on her right side. The Job's test was positive. The external rotation test was also positive. The bare head was negative, and these are her MRI pictures. It was from the outside MRI. The quality of MRI was not that great, where we can just thought it could be a just regular tear, and it was reported to be 24 mm. So we took for the cuff tear, and then we found this. So this is viewing from the posterolateral. There is a bit of tendon still attached to the footprint of the greater tuberosity, and this is during the rotation. So anteriorly subscap was intact, and the biceps was good. Just that the tendon was still attached there, and the reducibility, we can check that it was fairly coming back to the footprint. So this was the surprise. So it was kind of a split thickness tear. So the portion of we know about the delaminated tear, but this was a split thickness tear where part of tendon was still attached to the greater tuberosity, and the footprint, the bony footprint area was visible in this agent. So the usual cuff tears, we know that full thickness cuff tears, the tendinous portion is about 2 to 2.5 centimeter, and based on the amount of retraction, they are classified as small, medium, large, massive, and irreparable. And the usual cuff tears, partial cuff tears, we know that there is a partial articular surface, partial surface, or interstitial tear, and the full thickness tear, or the delaminated tears, where the portion of the thickness of cuff is delaminated into the superior layer and the inferior layer. So either sometimes the inferior layer is more retracted than the superior, or the superior layer is more retracted, or it is equally retracted. So unusual cuff tears or a surprise tears, what we can call, how often we see, are they important is the question. So that's our first ARS. How often we see this unusual cuff tears? So ARS. So the senior surgeon, sir, Pratap sir, so you see the unusual tears like this, where the portion of the tendon is still attached. So panelist, how often we see?
So I opted for the first. So I also see often that there is a intact part on the footprint, and there is a cuff tear from the rest.
Okay, so these are a little bit unusual tears, and before that, before knowing that, just a theoretical question. How many layers are there, histological layers of the cuff tendon tissue?
This is like a ragging question for all the consultants, and I think all the fellows and residents sitting at the back will probably know the answer.
Yes, sir. So that is very important to understand these unusual tears. That's why I put this. This is a theoretical question, I know. So yeah, majority have got it right. There is like five layers. The first is the most superficial layer, just 1 mm thickness. Then there is a densely packed fibers, the collagen fibers, and the deep tendon layer, it's about 3 mm thickness. or the loose connective tissue or the thick collagen band of 1 mm, and then the shoulder capsule comes. So invariably the delamination happens at the layer 2, 3 or 3 and the 4. So that is where the delamination happens. So the unusual tear, it could be a musculotendinous tear or a split thickness kind of a tear, where the musculotendinous tear, where the entire bony footprint is covered by entire tendon stump, whereas the split thickness, where there is a part of bony tendon visible. So that is the bony footprint is visible, and then the split, the delamination has gone with the greater tuberosity rather than with the cuff tissue. So that forms the split thickness tear. So these are not classified. So and these are not delaminated tears, but these are unusual cuff tears, split thickness tear. The delaminated ones are stays with the tendon and the muscle tissue. So are they important? Does our surgical technique differ? So that brings us to next ARS question. So should we take the distal remnants? So can we have the ARS? Ashish sir. So should we take down the distal stump, or we try to preserve?
I would preserve the distal stump, but it does not add biomechanical strength. So you want to use your medial stump, both layers, and do a double row. But while you're passing through the double row, you pass through the lateral stump as such. So you have got some collagen there.
Yes, sir.
For whatever reason.
So that's important thing. These are collagen tissue which adds to the thickness. Otherwise, the cuff would become very thin. So next, that brings to the next ARS, the last ARS question. So preserve it. So what to do? Just neglect the remnant and do a double row or a single row or a double row suture bridge or the transversus repair. So majority have gone for the C option, rightly so. That so we need to preserve it, and then as Ashish sir told that we can take the sutures into the cuff tissue and then kind of do the suture bridge repair. So how to do the repair? So this is the superficial layer and this is the inferior layer. That is the stump which is with the greater tuberosity, and there is a bare area. And just put the medial anchors, or just a fiber wire can be taken, and then the fiber wires can be passed into the lateral stump, and then taken to the medial stump tissue, and then we can bring that the fiber wires, and that closes the gap between the two layers, and then we can do the double row suture bridge configuration. So this does not, we are not doing any tight fixation, so that does not strangulate the cuff. So this is the picture where we can see that the distal stump is there still with the greater tuberosity, and we can see the bare area of the footprint, the bone area can be seen. So that shows that it's a split thickness tear, which is not classified. And so what I've done is I've taken the just fiber wire. This is a checking the reducibility of the cuff over the split thickness portion. So these are important collagen tissue, and of course this draws a blood supply from the greater tuberosity, and it is thick and it is large, so better to preserve it. So with the suture lasso, just free fiber wire was taken into the distal the lateral stump. Both the ends were taken into the stump, and it forms the loop within the stump, and then the same fiber wires can be taken to the medial stump as well. So these fiber wires, were taken into the medial stump, and without tying the knots, because we need to have a good approximation and there should not be any tight repair which may strangulate, and then the delaminated portion can get strangulated, and then we might lose, which may be the possibility for the retear. So on those were taken into the lateral aspect with the lateral row suture anchors. So this forms the crisscross suture bridge kind of a configuration for the repair. And this was about 1 year follow-up where there is a complete movement of the shoulder is there. She's been able to do all the activities. And we did 1 year follow-up MRI. Here we can see that the distal stump has healed very well, but there is small layer of signal which is seen there, but it has definitely healed well. And this is a 1 year follow-up MRI showing patient has a good result as well.
Rama, there is a question from Dr. Kapil.
Yes, sir.
Just a clarification, when we do a normal cuff repair, we expose the footprint, we sort of prepare the bony bedding, we're trying to get a tendon to bone healing. So in your technique, are you just relying on tendon to tendon healing because there was no, because the footprint is still covered with the stump? So how do you get the healing? And are you just, because it is a degenerated tendon, hypovascular, are we aiming for just tendon to tendon healing, or is that little signal that you're saying is that the healing is not complete?
So that's a good question, because how much we can take down the stump. So if the stump is just 5 mm or less than 1 centimeter, definitely we can take down the stump and then do the repair. But these are, we know that there's a thick cuff tissue, and if we can preserve that collagen, so, and if it is more than 1 to 1.5 centimeter of stump, then we can always preserve the stump and then do a good double row repair.
Ramakanth, this kind of a tear pattern seems to be tailor-made for a patch. Did that ever cross your mind to put a sandwich in between the two layers?
No, actually this was a surprise, because in that case I had that pre-op MRI which showed like a regular cuff tear, and it was completely intraoperative surprise for me, so never prepared for any patch or anything. Just thought that on table it's a good collagen tissue to preserve. So just need some bite into the tissue, and then we need that compression. So the double row suture bridge was planned intraoperatively.
Yeah. It seems that the location where the tear has occurred is where the rotator cable attaches and then runs into the subscap. So
Yeah.
it always looks that it's also a functionally remnant of the cable. Do you think that by repairing that, including that in your repair instead of removing it, it also might increase function at the end? What do you think?
This is not been classified. If you see that there was a bare bone, and just that small tissue, the small tendon tissue was there. So the cable was completely damaged there.
But it ran all the way to the front, and it seems that it came on. I don't think it was too much. There was a remnant there still.
Yeah, but whatever the tissue and there, we preserved it, just passed the sutures and
Yeah.
then got that same sutures into the medial stump and then did the lateral row repair.